From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews, and thank you for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. Today, we're going to look at language accessibility at select academic ophthalmology centers across U.S. metropolitan areas. And joining me is the corresponding author of that cross-sectional study, Dr. Cara Cavuoto. Dr. Cavuoto is a professor of clinical ophthalmology at the Bascom Palmer Eye Institute of the University of Miami Miller School of Medicine. Cara, thank you so much for joining us.
Thank you very much, Neil. It's my pleasure to be here this afternoon with you.
Maybe we could start with what language accessibility means. Can you just give me a layperson's description of what that term means to most of us?
What we were thinking of is that there's a lot of literature out there that established that language concordant care is very important in patient understanding, satisfaction, and outcomes. And that sometimes using an interpreter, it's helpful, but it's not what patients are really looking for. They don't feel fully satisfied by the encounter. So thinking about accessibility, we wanted to see what the concordance was between what patients were speaking and what the providers were able to speak with them. Thus, I guess, access to care in that unique aspect, or unique way.
Yeah, it's a fascinating thing to think about, since for many of us who are not proficient in languages other than English, we really have depended in our clinical experiences on interpreters and are thrilled when they can help us. So this is really something to think about. Maybe you could tell me which were those select academic ophthalmology centers? That's a minefield maybe, but what made them so select?
Truly a minefield in general. We did a two-stage inclusion strategy to look at major referral hubs, and we looked at the U.S. News and World Report hospital rankings, and then also the NIH ophthalmology funding data through the Blue Ridge. And we looked at those programs that overlapped on the two, therefore indicating they had a large academic and or research presence in our field.
And how many programs approximately did this end up being?
So in total, this was 32 academic ophthalmology programs across 28 different metropolitan areas. So this was all across the U.S. and included the 4 different U.S. census regions from the Northeast, the South, the Midwest, and the West.
Now we're going to talk about what the patients were proficient in for their language. How did you determine that at all these areas? How did you know how many of them speak Spanish as a first language or Chinese as a first language? How was that determined?
Yes, another difficult question. What we did is we went to the U.S. Census data and looked at the American Community Survey, or ACS, data to look at those limited English proficiency populations in these metropolitan areas. So there's a certain data table which comes from that survey, and it highlights the language spoken by those with limited English proficiency. Also allows you to see if they speak English less than well, very well, or not at all.
So that gives us an idea of how the patients in these areas might speak. How do we know about the ophthalmologists taking care of them? And maybe I should start with, was this just the ophthalmologists, or was this any healthcare provider interacting with them, like the front desk staff registering them, or the technicians measuring their vision? Who were the groups that you were going to look at interacting with these patients in terms of their language?
Yeah, so we decided to focus on the ophthalmologist as the physician who's providing the care for these patients. Although you raise an excellent point. I mean, the patient care really starts from even the people making the appointments over the phone or over the internet. So I think that's a great future study, and we'll happily pursue that one.
I like it. But let's go back to the ophthalmologist then. Now, at all these programs, how do you determine what the ophthalmologists speak? I'm not certain I've ever spoken to all of my colleagues at Johns Hopkins University to say, and are you fluent in Mandarin Chinese? Are you fluent in French? So how did you figure out what all the physicians then, the ophthalmologists, were speaking?
So for this, we looked at all the practicing ophthalmologists on each of these centers' websites, and we collected their publicly listed language from these institutional websites. Then, to make sure that we captured all the data that we wanted to, we went through other services and resources like Doximity, U.S. News Health and World Report, and Health Grades, for example, to ensure that we captured as many of the spoken or declared languages that they speak.
So then you're going to take the languages that you believe the patients in these regions are speaking. You're going to take the proficiency of the ophthalmologists in these areas based on information that might be available for what they speak. How do you then line it up to figure out what's going on at this program, this region of the U.S., that region of the U.S.?
Yeah, so that was a tricky one because as far as I'm aware, there's no defined method of looking at that. So what we did was we created a ratio between the language spoken by the physicians and the English proficiency of the patient population. And if it was 1, that means it was equally matched. Above would be overrepresented and under would be underrepresented, or there's a need there for physicians to speak that language for concordance.
I think I understand how you set this up. So what'd you find?
What do we find? It was definitely different than what I thought we would find, to be honest. We found that the availability of Spanish-speaking ophthalmologists was particularly low in several regions, including the West, even though these areas have very large Spanish-speaking populations. And we went back and did secondary analysis, and this did confirm this shortage of Spanish-speaking ophthalmologists relative to the needs of the population. Additionally, there were several languages that appeared to be overrepresented, but this was due to the ratio methodology used for the analysis. And that's because even though there was a proportion of the population who spoke this language, even if only one provider at that center spoke the language, it led to a greater ratio, which could look like overrepresentation.
So that's fascinating. I wonder if the patients recognize those challenges. Do we have any information, maybe not from your study, but in the literature, if this reflects how they feel? Because I had assumed, probably incorrectly, that if we had an interpreter, maybe they were somewhat comfortable with what we were discussing. But again, this is depending on the interpreters. When you're pointing out so many of the ophthalmologists may not speak the language of the patient who's walking in there.
Right, and I agree. Interpreters are a very important portion of our healthcare environment. But I think on a personal level, including that some of our co-authors have experienced this themselves with themselves or their parents, the interpreter just doesn't give that personal touch that they're looking for when they're speaking with their physician, and especially their ophthalmologist. An ophthalmologist is a physician who's going to be with you oftentimes for a lifetime, especially if you're in pediatric ophthalmology like myself. And so building those relationships and having those nuances on a one-to-one basis really do enhance the relationship.
So other than the limitations for the Spanish language that you identified, what were 1 or 2 other fairly large challenges that you identified in terms of discrepancy or discordance in the language spoken by the patients, let's say, and the language that we think was available from the ophthalmologists in that region?
Yeah, another discrepancy was actually with patients who spoke Vietnamese. So we found this was very much underrepresented and underserved as far as their accessibility to language proficiency in their native language.
So how about some limitations here? Do we know how accurate those public sites are? Has anyone gone into, let's say, details at your institution and said, let's look at what you have, and now I'm going to go talk to that ophthalmologist and say, is it true you don't speak Italian when I hear you speaking that all the time to your parents? Is there a disconnect in some of the data that you have, or are we just depending on what's publicly available so far, and this will have to be looked at in the future?
Neil, you hit on a very important limitation. One we definitely mentioned as well is that physician language data was obtained from these publicly available websites, and it's not verified at all. So this may actually underestimate the true language capacity or fail to capture the true clinical proficiency of providers. It would be an ideal study if we could actually go back and there was some kind of metric we could use to truly test proficiency in a language, maybe a certification or some kind of method of doing that. And also, we treated language ability as a binary variable rather than a graded fluency. And that may really very much oversimplify the real-world communication ability. Just as you hinted at with Italian. Maybe I speak it at home with my parents, but I don't feel comfortable enough putting it on a website saying that I speak Italian.
Of course, this may have overestimated things. For all I know, something made an ophthalmologist put down some language that, okay, they can speak it, but Maybe they're just not that comfortable talking about the nuances of doing DSEC or doing strabismus surgery or something like that.
Absolutely, absolutely. And how we would achieve that goal of verifying that, I'm not sure in this moment, but definitely something that would be important for the future going forward as more and more patients have access to these online resources and will be searching for providers in that way.
So based on what you found, are there any changes you'd recommend so far for these programs, or is this just the first step and more information needs to be collected before any sort of institutional adjustments or changes are made?
Yeah, you're spot on. This study doesn't directly evaluate patient outcomes, but maybe it'll influence how academic ophthalmology departments think about language access, because this is kind of a new variable that we're considering. And our findings do suggest that interpreter services alone may not fully address these access gaps, particularly for high volume languages like Spanish. And maybe when you're thinking about workforce planning, recruitment, and training, especially in these regions with large, limited English proficiency populations, we have to think about language capacity as part of this equation.
Well, this has been truly eye-opening and important to understand. And I want to thank you and your co-authors for putting this information for us, and we look forward to hearing more about it and perhaps how we might be able to always improve our communication with our patients in the future.
Neil, if I may just take one moment, I do want to acknowledge my co-authors. There's 2 medical students, an undergraduate student, and a future dental student as my co-authors. And without their input and their hard work, this would not have been possible. So I just want to acknowledge everything that they did to make this manuscript possible.
Well, we're so thankful to them for doing the lion's share of the work and putting this together, and for you for leading them, and for you for sharing this with us today. Thank you, Kara, so much again.
Thank you very much, Neil. I appreciate it.
I'm Neil Bressler, and I've been speaking with Dr. Kara Cavuoto on language accessibility at select academic ophthalmology centers across U.S. metropolitan areas in the United States. You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks to everyone for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.